Despite a lot of new understanding about bile duct injuries and a lot of different maneuvers to prevent this injury, such as the critical view of safety put forward by Dr. Strasberg, bile duct injuries are still a major problem in Canada. And in talking to Juan, I suspect that it's also a major problem in Colombia and other places in the world. So what I wanted to do was to come at it from a completely different aspect. I wanted to talk about bile duct injuries with a sort of a cognitive approach in terms of how we think about surgery and how we do our surgery and how these injuries actually happen. So I want to talk about, first, a little bit about new cognitive theory, shortly what's the at-risk situation that causes this injury, and then our thinking. What is it about our failure of perception, failure of correction that causes these injuries? And lastly, I'll put forward maybe a solution that might help us prevent these horrible problems. So, you know, our thinking doesn't just go from one simple thought to the next. We have a complicated system where we have two basic structures of thinking. We have a fast thinking system, which is automatic, it's intuitive, and it's largely subconscious. So we spend most of our time in this mode of thinking, and we use a lot of heuristics, shortcuts. We move through our environment very quickly without thinking. And surgeons do that, you know, experienced surgeons do that when they operate. They don't have to think a lot about what they've been doing, and they just move through the operation, and talking to their assistants and nurses. There's a second type of thinking that is more effortful, and we have to stop and analyze and really go hard at what we're doing, and that's system 2 type of thinking. The second thing that cognitive psychologists have given us is the idea of cognitive maps. And I'll just read this. Cognitive mapping is a process composed of a psychological transformation by which an individual acquires, codes, stores, and then has to recall information about their relative locations and attributes and phenomenon in their everyday spatial environment. And this is the spatial environment that is really important for surgeons. And most of the studies on cognitive maps are done in large-scale environments. But when you think about it, surgeons in our small-scale environment also use cognitive maps to navigate our way through our operations. So yesterday, when we wanted to go to the bar, we have a cognitive map in our head in terms of how we want to get there. We know we go out the door, we turn left, we have some landmarks, and landmarks are particularly important for navigating. We go down the stairs, we turn left, and then go 3 blocks. So in that way, we know in our mind how to get to our location. And surgeons do the same thing when they operate. They use landmarks to move around in their small-scale environment. So what is it about bile ducts that are particularly at risk for injury? Well, I mean, I divide it into 3 parts. It's the anatomy, perhaps the local environment around the gallbladder, and then the surgeon himself. And the anatomy, of course, proximity is the huge issue, because the bile duct comes right off the common bile duct, or the cystic duct comes right off the common bile duct. It's often the same size. If we pull on the Hartmann's pouch, it often lines up. And any type of inflammation tends to squeeze the gallbladder down onto that structure. So it's proximity that is the major problem. The other thing is that often a lot of the anatomy of the area is invisible. It's covered by fat and inflammation. And surgeons, most general surgeons today, don't have a really good concept of what the porta hepatis is like. They don't explore common bile ducts anymore. So their cognitive map of this area might might just be the gallbladder, and then they don't really have an idea of the complexity of the common bile duct, the sectoral branches, and the placement of the right hepatic artery. So that's sort of a result of ERCPs and hepatobiliary surgeons taking over this area. So I'll move on. Failure of perception is probably the first thing that happens to us when we have a bile duct injury. And this is a quote from Lawrence Wei's landmark paper in the Annals of Surgery. The visual system implicitly makes plausible assumptions about the environment as it analyzes the imaging information being processed on its way towards the conscious mind. And because assumptions and simplifications, visual perception provides only an estimate of reality and perhaps not the real thing. So when we look at a scene, and particularly a scene like the subhepatic space, there can often be very little information. The information can be ambiguous. There can be a lot of noise and not a lot of signal. And in this diagram, it sort of illustrates that. There's dots all over the place. There's really an incomplete picture there, but our minds are very good at taking that information and producing an interpretation. So if we all look at this, almost instantly we can pick out that there's a dog sniffing his way towards a tree. So our minds are very good at filling it in, and often, usually we're right, but occasionally we can certainly get it wrong, and we can get it very wrong. The other thing that we can often get wrong is a situation where there's an illusion. And that's where our senses, both our system 1 and our system 2 thinking, universally make a misinterpretation. So when we look at this, we look at it and very quickly we can tell that this line is exactly the same as this line in length. This is the Mueller-Eyre illusion. And even when we look at it, we think very carefully about this in system 2 thinking, we see the same thing. And it's only when you actually measure it that you realize that these lines are the same. And so this is a situation where we have to learn not to trust our initial impressions and even our thinking if we want to get our interpretation right. So how does the misperception happen with the bile duct? How does the illusion happen? How do we make that misinterpretation of the anatomy? And this is Hugh's diagram in terms of how he thinks it actually happens. The bile, when you pull on Hartman's pouch, you can kink the bile duct and straighten the common duct out with the cystic duct. And then if we look a little bit too far to the patient's left, we see a triangle, and that triangle looks very much like the hepatobiliary triangle. And we misinterpret the cystic duct for the common bile duct, and then now we're on the left side of the common hepatic duct, and we misinterpret that as the underside of the gallbladder. So it's an optical illusion. And I kind of like to think about it a little bit differently, and using that idea that we have a cognitive map, and every surgeon, after years and years of training, has a map of the gallbladder or the subhepatic space in their mind. And I use this to just illustrate maybe what we think about it, which is obviously a lot more complicated than that. So what may happen is that when we look at that area around the gallbladder and say there's some inflammation or there's a lot of fat, and we're using the bottom of the gallbladder and Hartman's pouch as our landmarks, which aren't really very good landmarks at all, and maybe this space is closed down a little bit, we place our cognitive map in the wrong spot. So we have spatial disorientation, and the map is placed too far to the left and maybe a little bit too inferior. And you can see what happens when you've got your map in the wrong place, you just make a whole bunch of wrong assumptions. You assume that the cystic duct is here, when in fact it's the common bile duct, and this is divided, and the surgeon then follows the left side of the common hepatic duct up, and when he thinks that, oh, it's about time I started to move into the gallbladder plate, the cautery is used, and it divides very quickly across the common hepatic duct. And it can be a very high injury if the surgeon takes it up and tries to create a very big critical view of safety. So the bile duct is divided in two places. This is a classical bile duct injury. And it's interesting that the surgeon may not even realize that they've done that, because the second division brings them right back into the normal plane. So 70% of these injuries, the surgeon didn't even realize that they took out a chunk of common bile duct. And that's where the real catastrophe can happen. So you can see that the way this happened is the surgeon was spatially disoriented, and they placed their cognitive map in the porta-hepatus triangle, and then instead of the hepatobiliary triangle. So how is it that after we've made this mistake and we're operating in the wrong place, that we don't stop and say, oh, something's wrong? What is it about our failure to correct this problem? Well, human beings have a whole raft of cognitive biases in the way we think that sometimes prevent us from making the right decisions. And some of these that are applicable to surgeons would be first impressions. When we make a decision, we see something right away, our first impressions have an overwhelming influence on what we do. We tend to have a bias towards believing what we're seeing, and if we want to unbelieve it, it takes system to effortful thought. The other thing is that once we start along a path, we often don't see the alternatives. So if we're starting to dissect, we don't realize that, oh, we should back up and look other places, or we should check our orientation, or maybe we should just stop and do a cholecystostomy because there's tremendous inflammation. And this is also called availability bias. Now, we're surgeons, we're not internists, so we have a propensity for action and to move forward. And we often feel like moving forward is going to eventually solve our ambiguity problem. And lastly, probably the biggest cognitive bias of all is confirmation bias. And that is when what human beings are particularly good at is interpreting new information so that prior conclusions remain intact. In other words, we just keep going along the same line, and we get into a situation where we have cognitive fixation, we just think about that, and we can't change the way we've started, and then we just continue with the same plan. And you can see how that would happen when you're spatially disoriented, like a pilot, and you're making continued moves. So I wanted to put forward a possible solution to this problem. And that's quite simply a bile duct timeout. And we use timeouts more and more frequently now. The safety checklist is a good example of a timeout. And these timeouts are really a way of de-biasing our thinking and allowing us to stop, move back, and perhaps use a little more system 2 type of thought before we get started. Oops. Can you turn it back on? So, what I'm suggesting is that we use what I call a bile duct timeout, and we use landmarks to set our cognitive map and orient ourselves so that we know that we're operating in the right place. So, what I'd suggest is that you stop and it just takes seconds, back the camera up, because often laparoscopically we tend to get ourselves so close that we lose track of all the landmarks that you would normally see in an open operation. And then just look for the landmarks around the gallbladder. And if you look carefully, probably in 80% of the patients, you can see the bile duct. If you push the duodenum down, you can see the bile duct often just above the duodenum, and just below the hylar plate, you can often see where the common bile duct is. Hugh gave us a good idea in terms of looking at the sulcus of Brugge. It's present in about 80% of patients, and we know if we're above the sulcus of Brugge in our dissection, we are probably safe. But there are a number of other landmarks that we probably wouldn't normally look at. If you look very carefully on the left side of the porta hepatis, you can see the left hepatic artery pulsation. And that's useful, because if you're close to that, you're operating in the porta hepatis and not the hepatobiliary triangle. And similarly, above that, there's the umbilical fissure. And again, that shows us if we're too far to the patient's left. And lastly, the duodenum and stomach are useful landmarks, and they're seen in almost all patients. And if we're too close to them, we're probably not in the right place. So, in conclusion, we should use our new knowledge of cognitive psychology to help us prevent these injuries and set our cognitive maps in the right place, and using a little time out, probably before you start your dissection, and maybe certainly before you clip any structure, may perhaps help us prevent these horrible problems. Thanks very much.